This is a woman that presented with constipation, abdominal pain, and lower abdominal pain, tenderness, and also weakness in her legs. She is up to date with cancer screening because she did the recent colonoscopy, mammography, and also a recent pelvic exam that were all negative. The woman is 77 years old. So at the end, the doctor prescribed a CT scan that we can see here. So I'm gonna scroll and let me know what you see.
So far, I'm seeing a lot of haziness in the mesentery and the left pericardial gutter.
Yes. So basically, we saw here some disappearance here on the left. Can you see my pointer?
Yes.
As well? This here and here that they thought it was carcinomatosis. But if we look at this case, if we look down in the pelvis, we don't see abdominal masses. I think this is the ovary, but I don't see big things down here. And so the patient underwent a biopsy of the lesion. So we biopsed the lesion, and the result, unfortunately, is already here. So the diagnosis was amyloid deposition, which I thought it was strange for the case. And in the meantime, the patient also underwent a bone marrow biopsy. And in fact, she was diagnosed with a neoplasm with the kappa light chain plasma cell neoplasm. And so this was a case of primary amyloidosis with the that is affecting the mesentery. And so I was looking into the literature and I didn't find anything. But luckily, our dear Cookie Manias Twitter posted a tweet like at noon, 2 hours ago, about the recent review that was published in Radiographics about classification of amyloidosis in radiology. And so they changed the classification because before we knew it was primary and secondary amyloidosis. So actually now there are a lot of different types, but our case was a case of primary amyloidosis. And so it is caused by the abnormal production of light chains by the plasma cells that can deposit in the various organs and affect and produce symptoms. So in fact, our patient had some of the symptoms that are associated with amyloidosis, including the legs, and she also experienced fatigue and constipation. And it's important to notice that it can also affect legs and arms because there is can be a neuropathy. If we talk about, instead, we can go on talking about imaging features. So most often the chest is interested by amyloidosis with calcified lymph nodes, but also calcified peripheral mass, like in this case. But these findings are not very specific, especially the interstitial septal thickening, and also micronodules that can mimic different kind of chest disease. And it can also affect the heart with late enhancement of the myocardium and thickening. But if we look at the abdomen, so it can affect the kidney with this appearance that can mimic nephrocalcinosis of, like in this case, and an appearance of the liver that they call a mottled appearance, but also it can cause calcification in the abdomen and in the mesentery, like we can see in these cases. So I think these are cases that are more similar to our case with this soft tissue that we can see in the omentum and in the mesentery. And there is also an appearance that can mimic that fibrosis, like in this case, that we see this mass forming infiltration surrounding the aorta. And interesting enough, so there is an evolution of amyloidosis that produces this calcification. So this is the same patient 5 years later, and this is still in the most recent radiographic paper that was just published. So I'm done.
That was
with
outstanding. And
Thank you.
I don't think we've had any amyloid cases so far, so that was a great review. That was really cool.
Thank you.
Nelly, you want to go?
Yeah, I could try. I'm gonna kind of alternate with the other presenters so I can pull up cases as we go. Great. Okay, so this patient has initially presented with lung cancer. Here's the presentation. There's all these like nodularity, and then there's pleural effusion and kind of like pleural involvement. So this was biopsied and treated, and this patient had did really well after treatment. 5 years later, patient developed metastasis to the liver. And then was treated with a tyrosine kinase inhibitor, and now has been NED for the past 5 years. So this is a special kind of lung cancer, and it has this, it's just, you know, this precision medicine stuff, we've been hearing about it for so long, and now it's sort of like coming to fruition. This patient had an ALK rearranged metastatic lung cancer, and that causes, and so there's a special tyrosine kinase inhibitor that ALK is a tyrosine kinase inhibitor, tyrosine kinase, and so there's a targeted agent to directly for ALK mutation in the lung cancer, and so that's like fortunately what this patient had, and so now has been NED even though he had like pretty significant metastatic burden because he had this mutation in his lung cancer. Isn't that amazing?
That is amazing. I've been meaning to learn all the different immunotherapies, but I haven't been able to yet.
This one is not an immunotherapy. So immunotherapy, I think, is a class of drug for like CTLA-4 and PD-1 inhibitor that activates the T cell pathway. Tyrosine kinase is not an immunotherapy because it doesn't go through the tyrosine, it doesn't go through the T cell pathway. So these are just targeted agents. So we don't use like iresis for this, for example. So, you know, the tyrosine, I think there's like 17 or 18 different tyrosine kinases, and these are various like oncologic pathways. Like I think GIST has a tyrosine kinase activation, or and like actually multiple tumors. So I don't think these are considered immunotherapies. They're just TKIs.
Cool. Okay, Steve, you want to go?
Sure. Let me show my. These are two exams. These are outside studies to me, and I was just reviewing them with a surgeon. There, it's an abdominal lesion. This is old, so this is, let's see, about a year in advance of this one, the more recent. So, not an inobvious finding here of fairly well circumscribed mass with both gross fat and soft tissue. But, you know, my question to the group is, what's the differential? Is it different than a liposarcoma? And has anybody seen a liposarcoma that looked so circumscribed? And this would be, if true, I guess, mesenteric. Whoops. Mesenteric. The bad parts of this sarcoma would be, if it's a sarcoma, would be the soft tissue component. That looks like it's increasing over that interval of 1 year difference. Any thoughts?
I have seen well circumscribed ones. I have not seen one in the mesentery, but that would be my big suspicion here is a liposarcoma.
Yeah, I mean, I put this on a most likely liposarcoma. I mean, you know, could a teratoma or something like that look like this? I don't know why you would get one there. Or, you know, you get maybe non-pancreatic pseudocyst, but why would it have fat in it? Or maybe a chylous cyst, you know, but then, you know, maybe it would have a fluid level and not a rind of tissue looking stuff. So for me, it's I guess a circumscribed liposarc, you know, and maybe it's increasing in grade between these, or it's just low grade the whole time. I don't know, but yeah.
Why haven't we biopsied it?
They didn't want to biopsy it because of the location behind all these bowel loops so far. So it's probably going to just go to primary resection. And we were talking about the resection. It's in front of the IMV here, and it's lateral to the mesenteric root. It looks a little bit mobile. It sort of changes position. So before it wasn't really in close association with you know, D3, D4, and then on this one it kind of abuts D3, D4, but I don't think it's connected to it. If you looked at the coronal, there's basically a plane that's pretty well developed between those two. So I think it's just a little bit mobile.
Yeah, regarding the biopsy, I think they could have come from a retroperitoneal approach. I saw like a window there. And we do sometimes biopsy. We don't, if it's a classic, you know, like just slam dunk liposarc, we don't usually biopsy it. But if it's on the spectrum of like, is this just a lipoma versus a liposarcoma, we'll biopsy it and send it for MDM2 FISH analysis. And that can help differentiate between a lipoma and a more atypical lesion. And I would say this one, especially because it's growing that soft tissue component, the soft tissue itself does not necessarily mean it's dedifferentiated. You can have like sclerosing subtypes that are dedifferentiated, but the fact that this has changed so much in a year, I would be concerned about it.
Yeah.
But it hasn't grown that much, so that's good.
No, it really hasn't. I mean, I don't know. I didn't do a measure on it, but
maybe it's just progressively sclerosing.
About 6.5 centimeters. And it was the same, basically. It hasn't changed in size. It just changed in internal complexity. And you're saying like maybe this was your window for biopsy if you would have chosen.
Yeah, but I have a doubt about the biopsy because since it is so dishomogeneous, I'm afraid if you biopsy not in the right spot, it can be even inconclusive. What do you think? And also another question that I had, why was not removed in the first place?
Well, I don't know. Probably some reluctance to seek or pursue care, but the person I spoke with, the surgeon, was urging the patient to get it taken care of.
Mm-hmm. because I wouldn't
Regarding
like to keep this mass myself.
Regarding your question about the biopsy, I don't think it would be that difficult. We do generally try to target the soft tissue, the components, to try to see if we could get the highest grade component. Given the lack of difference in size, I wouldn't be surprised if this was just like a sclerosing liposarcoma that was changing over time, but it wasn't dedifferentiated. But we definitely target the soft tissue areas. We do large core biopsies, and the FISH analysis and the other molecular analyses are really important because a lipoma and a well-differentiated liposarc can just look like fat cells. So they need to do those extra tests.
Okay.
I was wondering, can this be myelolipoma, extra adrenal myelolipoma?
That's actually another thing I added the differential to the surgeon was maybe an extra adrenal myelolipoma could be considered, but again, mesenteric, I don't know.
Yeah, we found it. What I've shared the link in the chat box.
Yeah, Gitanjali just shared a article. It looks somewhat similar, more blobby looking. I haven't seen a myelolipoma change its myeloid component that quickly, but I think it's a great idea. So Steve, you'll definitely have to give us the follow-up.
Yeah, sorry, I don't have that yet.
I'll post it on my computer here.
And in the DDX, you had already, it was like a chylothorax or chylothoracic cyst or something like that. We had a case that this thing reminded me of that Cookie called. I think it might be worthwhile to just send her a screenshot or something, because it looks kind of similar to that.
Yeah, I've seen chylous lymphatic cyst look something like this, but again, the way that things developing a rind on the outside, I thought maybe wasn't fitting for that.
Yeah, that encapsulated look kind of made me nervous too.
Okay.
Who's sharing now?
It's Aarti. Can you see my screen?
Yeah.
Okay. So this is an interesting case. I want to know your thoughts. Youngish woman who presented with pelvic pain. So you can see the uterus is here. This is, we thought, an adnexal mass with some cystic components, solid components.
Do you have the in and a post phase or like the fat sat sequences, either one?
Yep, I can show you in a sec. It was enhancing the solid part. Cystic part was not enhancing. In and opposed phase. Make sure this is going through there. Okay.
What are your thoughts, Nelly? You're looking for some gross fat inside?
Yeah, like dermoid.
Not dropping out. Somebody's chatting in. Serous carcinoma of the ovary. That was what I was concerned about.
It looks like a worrisome or surgical adnexal lesion.
Oh, that's 5.
Yes, definitely all those things. Where's my? I thought it was very concerning looking. Where's my pelvis? Well, anyway, so the patient went to the OR, and this turned out to be cystic degeneration of a fibroma. And actually, they have a second lesion over here that was a typical fibroma. And this guy was T2 dark and enhancing. So this was an sort of ORADS 2. We were wondering if this could be a fibroma, but we thought this was concerning for an epithelial neoplasm. So I just wanted to make you guys aware there is this version of fibroma that's cystic degeneration. It is rare. I did do some lit review, so I want to show you a couple of things. There is some case reports about cystic degeneration of a fibroma. Here is a series from Japan where it looks kind of similar. It's kind of with that like frondy appearance. They had a couple that were, yeah, and then this one too, also very T2 bright with that cystic degeneration. And then this is a AGR article about ovarian fibroma. And the interesting thing they said was that the larger the lesion is, the more that fibromas have degenerative changes, as well as peripheral subcapsular cystic areas. So they gave some examples like this degeneration, and then these like subcapsular cysts. My case did not look like that, but anyway, it was great for the patient. Just turned out to be a fibroma. So I don't think I honestly wouldn't have called it prospectively, but just interesting to know about. And I don't know, maybe there's something about this that's specific, but it looks, looked too aggressive to me. Okay.
Can I share a case?
Uh-huh.
Would that be okay if I interleave with you?
Yeah.
Okay, thanks. Patient history of right colon cancer, satisfies right hemicolectomy, and then presented with rectal bleeding and had this. So this is obviously a low rectal cancer. It looks like probably invading the sphincter complex as well. And then had an MRI of the abdomen done elsewhere. And so it's series 7 here. Anything else that anyone sees?
Is there maybe another colon lesion? I don't know.
Yeah, exactly, right here. At the splenic flexure. This was seen on colonoscopy. And so, so this patient had 2 different, this was concurrently during the evaluation, 2 concurrent, and it was subsequently resected. Patient was genotyped, and patient had a mutation in, what is it called? Basically, the patient had Lynch syndrome, had a MSH6 mutation. So I didn't know this, but multifocal cancers can occur in up to like 5% of patients with colorectal cancer, and apparently 30% have some kind of they share clonal origins. It was thought that they were all independent tumors, but in up to 30% they share mutation, clonal mutation. So this was a really interesting case of multifocal colorectal cancer in a patient who was later found to have Lynch syndrome.
Interesting. I was just looking up because I can never remember the other cancers they get. And apparently they get gastric, pancreas, ovarian, urinary tract, and prostate. So, but I guess colon is the most common. Cool. Okay, I'm going to share. This is a good follow-up to your rectal cancer case. So this patient had an APR, and this is their follow-up exam. So I want to know what you guys think about this.
This is following an APR.
Uh-huh.
So far, I think the stuff in the middle there might be following fat attenuate or fat intensity, isn't it?
Yeah. So this is the fat sat.
Like fat
here.
necrosis.
Yeah.
Exactly. So what kind of fat necrosis is it? Like fat necrosis of what?
Encapsulating fat necrosis.
maybe they shoved a piece of omentum down there. Sometimes they'll take
Exactly.
the momentum and shove it into the space to fill space and to keep things from adhering to bowel.
Exactly. So this is an omental pedicle flap that has undergone fat necrosis. So even though the edges look kind of gnarly here, this whole thing is fat, and none of these areas of nodularity demonstrated restricted diffusion. Just to show you, this is a radiographics article about omental flaps. And so what they do is they'll cut but keep vascularized a portion of the omentum, and then they'll flip it down. So basically they've separated it, but the vascularity is still there. And then they'll flip it down and put it in the pelvis. That helps other things from falling in the pelvis, and it also promotes healing. They do this in a lot of different surgeries, like even Whipples. They'll flip a omental flap up onto the Whipple bed, so you can also get omental pedicle necrosis after a Whipple too. So anyway, just not to mistake this. Initially, I was like, oh, is this mucinous tumor or whatever? But obviously it's satting out, so it's just fat. Okay, Nelly, do you want to go?
I've seen fat necrosis be a bit of a fooler because it's not, sometimes on CT, it looks a little, if it's very indurated, it can look like almost soft tissue attenuation. I've seen people go for it because if me, FTG avid even. So
yeah,
it can be a real mimicker sometimes.
yeah, and it can have like nodularity in it.
Yeah.
But yeah, the key is the sort of fat like appearance and
Right.
rounded appearance.
Okay. And I'm going to show you. Okay. So this patient has sort of like chronic perianal disease. There's like fistulas. The rectum is really thickened, sort of extending up to the rectal sigmoid. You know, if you didn't know this patient's history, like, of course, like the first DDX that comes to probably most of our minds is Crohn's, right? Especially with all of this perianal fistulas. And I didn't know this, but I recently learned about this thing called granulomatous colitis. So granulomatous, so this happens in a patient with Hermansky Pudlak syndrome. Hermansky Pudlak syndrome. Let me just drag this thing over. And they get
Definitely never heard of that syndrome.
Yeah, no, I had to look it up because it was new to me too. Okay, can you see my OneNote?
Yes.
Okay, great. Oh no, that's not the Pudlak syndrome. The Pudlak syndrome is here.
I like how you're still going strong with OneNote.
I love OneNote. I love it. Okay, so resume share. So this is a case report. So this patient had this genetic syndrome called Hermansky Pudlak syndrome. There's a granulomatous colitis that occurs in this patient population with this specific syndrome. And so it looks just like Crohn's disease, I guess any kind of IBD. Like it has a thickening of the rectum, colon, rectal sigmoid, which this patient had, and so they treat it actually the same way. So this patient's been on treatment and she's getting better, but this is an example of granulomatous colitis.
And Nelly, there's nothing on imaging that would help us get that, right? Like it would just be a path diagnosis, like they saw the granuloma.
Yes. Yeah. I mean, when the patient came already with a known a diagnosis, and so this was like part of the GI complications associated with HBS syndrome.
Cool. Okay, I have this case. The patient has a thrombosis of their SMV and their proximal portal vein. And I'm wondering what you guys think about this area here.
Looks artifact-like.
It's not an artifact, But when I first saw this, I thought that this was like a non-occlusive thrombus within part of the portal vein.
Inferiorly, like in segment 6 right there, it's not continuous with the, there's like this continuity into the segmental, like there.
Exactly.
Like,
so what is this actually? What is this black thing?
I mean, it could be clot. What else could it be? Air.
Is the portal vein occluded and there is like a portal biliopathy, collaterals around the biliary bile duct?
Exactly. So that black thing was the bile ducts, and you can see the bile duct here matching up with where that black thing was. And all of this stuff around it, all the enhancement around it is the peribiliary plexus, which is engorged from the cavernous transformation. So it's just kind of
wow.
a cute fake out. Like it looks like a thrombus in the vein, but it's actually the bile duct with engorgement of all the collaterals around the bile duct. Eventually, portal biliopathy can sometimes cause like biliary dilation and obstruction. But you can see here, this bile duct is just like surrounded by like all these little venous collaterals. So.
Interesting.
Yeah. Nelly says, great case. Cool. Okay. And I'm going to show one more and then I'm going to give it back to you, Nelly. This is just a quick one. This patient has an LVAD. And you guys notice anything? So this is the left ventricular outflow tract that goes from the ventricle. It's like a tube that goes from the left ventricle and then it'll go all the way up to the aorta. And it's surrounded by a sheath. And there's often a little bit of fluid in that sheath. But in this case, the sheath is disrupted and there's a fluid collection here. So they were basically concerned about rupture of the sheath with like an inflammatory phlegmon/abscess adjacent to the LVOT. So the LVOT is still patent, but the sheath is disrupted and then there's this collection. Okay.
Okay, I'm going to share my screen. Okay, so this is a patient. See if I can get better images. Okay, this one. So it's a patient with pancreatic cancer, and it's here involving sort of the head neck junction, definitely the tail, and encasing the vessel. The celiac axis is right here. The SMA, which is more inferior, I think was okay. Right there, there's SMA, it was clear. So when I look at this, like, it's complete encasement of the celiac axis. I mean, I think unresectable. Based on NCCN definition, I think this would be unresectable cancer. And what I learned recently, so when I looked in the note, the surgeons wrote type A, locally advanced pancreatic cancer. And I didn't know that there was a type A and type B advanced pancreatic cancer category. And so I'm going to share my screen with you. And here it is. Okay. So it's from this paper here, locally advanced pancreatic cancer, and there's two types, type A and type B. This patient was considered type A, and I guess these patients, they will try neoadjuvant chemoradiation to see if they can resect the patient. And this is kind of neat because these patients, type A and type B, were traditionally considered unresectable. So in this patient, there's 360-degree encasement of the celiac axis. So here, right, it's greater than 180, but as long as it doesn't extend to the aorta and is amenable to celiac resection, then they can try to aggressively treat this with neoadjuvant chemoradiation, followed by surgery. Isn't that crazy?
Yeah, Nelly, just last week I presented a case just like this that they did an Appleby on, which is basically that
Wow.
procedure, the celiac axis resection.
Recon. Yeah.
And they just need a patent GDA, but even better if they have a replaced hepatic artery from the SMA. But yeah, they can resect celiac and SMA. So I tend to not say resectable or unresectable in my reports. I just give the local advanced interfaces and stuff.
That's
so I
amazing.
didn't know about the type A and B. That's cool.
And, you know, I've always just said greater than or less than 180-degree involvement, but now actually you can get actually even more granular, right? So type B is, I mean, if it's an SMA encasement, if it's under 270 degrees, it's still potentially resectable. So I never really think about describing it, you know, beyond 180 degrees because but I guess we are changing, and, you know, surgical approach is changing and adapting. So it's great.
Yeah, I still think it's very rare to, pretty rare to resect the SMA. I was asking my surgeons recently about it and they said that they just don't do well. It's just like a very high rate of recurrence and then the grafts usually don't do well. So I think that's less common. I mean, even the celiac access, these are uncommon things if they're still encased to resect those arteries, but it's possible.
Yeah, I was, after you showed that case, I was chatting with my surgeons as well about that, and they tend not to pursue that because the outcome picture for them is so generally poor.
Yes, yes. I also was studying a bit about pancreatic cancer, and actually, when the margin is involved, even microscopically, the survival is not great. So at that point, it's kind of an ethical question if you should do surgery or not, if you can improve the survival.
Yeah, still poor prognosis, but there are some new drugs that are working better.
Can I present my last case and then let you have?
But in that case, Nelly, that was it did not undergo neoadjuvant yet, right? There was a first diagnosis, right?
Nelly, if you're talking, we can't hear you. But Francesca, I think it was before neoadjuvant therapy.
Yes, before neoadjuvant. Yes, that's correct.
Okay.
Yeah.
Thank you.
Okay, so this was, I thought, such an amazing. Okay, so this patient came in with abdominal pain after eating. So they were looking for mesenteric ischemia. But there was something else. There was no mesenteric ischemia, but there was something else. This was Cookie's case that she shared that I wanted to show. Anything? Non-bowel findings?
Is there like some pericholecystic fluid with hyperemia of the liver?
Yeah.
Concerning for cholecystitis?
Yeah, so there's this like super subtle kind of cholecystic or hyperemia of the liver, maybe the mucosa of the gallbladder is a little bit enhancing, and there's stones. Then there's one in the cystic, the gallbladder neck, right? Patient didn't have right upper quadrant pain, and this was a totally incidental finding. So what would you do now?
I'm still concerned about cholecystitis. Do they have risk factors where they wouldn't be able to have pain, like diabetes or?
I don't think they had any risk factors. So that's right. So patient, they're like, they're fine. They got discharged, and Cookie's like, no, you got to come back. So I got ultrasound, which is consistent with, acute cholecystitis. Labs were abnormal. And so patient was fine though. He's like, I don't have any pain, blah, blah, blah. Anyways, the surgeons took the patient and did a lab chole, and it came back as necrotizing cholecystitis. acute necrotizing cholecystitis. So that's the reason why the patient didn't have any pain. It's because all the nerves are all kind of infarcted, dead. Oftentimes we see stuff on imaging, but when it's real, and even if it's discordant, it's still worth pursuing.
I agree. Although one of my surgeons always tells me, treat the patient, not the scan. When I'm trying to convince him of something, like, look, I see it. And he's like, the patient's fine. Yusuf says he has some cases. You want to present?
All right. Okay. So this was an interesting diagnosis, although radiologically maybe not as much of a fascinating picture. But this is like a patient with with this big lymphadenopathy, and they were trying to find the primary. And I believe there was a PET, which we don't have access to, but the PET lit up something in urethra. So they got an MR. And you can see, again, you see very heterogeneous abnormal lymph node. And then at the very tip of urethra, you see like this little bit of abnormal signal there. And again, on contrast, just some irregularity there, but definitely something enhancing, and this corresponding to an area of active PET. So the patient went to OR, and again, it's not as exciting radiologically, but pathologically, this ended up being urethral melanoma with mets, which I didn't even realize you can get urethral melanomas, but this was primary urethral melanoma, it appears, which was very interesting. They took the whole thing out, and the patient's doing okay. This is like a few years back. Aarti, have you ever seen urethral melanomas?
I do have one in my urethra talk, but it's a rare thing. But I think it's kind of related to like the same reason why, you can get squamous cell of the distal urethra. So I think of like these things as like the distal aspect of both the male and female urethra is kind of made of skin. So you can get melanomas and stuff, like same like with the vagina and the anus. Right,
that's what I thought, but it was like when on the resection that the primary nidus was this, but then they went all the way up to like bladder base and stuff. It was kind of interesting. All right, so then the next,
and it wasn't T1 bright, right? So it shows you melanoma can be like
no. Right, it's all dependent, right? So it just basically didn't have a lot of melanin, I guess, in it, but it was fair. But patients did not, right? Okay, so the next person, just make sure. Okay, good. It's just a nice example of this entity. Older patient, fairly sick. And you can see that, the gallbladder is kind of contracted. There's a little bit of, can you see it? Let me just zoom it in like this.
I think you might be sharing the wrong screen because, okay, yeah, now I can see.
Yeah, okay. So you can see that, the gallbladder is kind of contracted. You can see actually a little bit of contrast extending into the gallbladder, and there's a little bit of focus of air there. And next to it is this big goomba in the gastric antrum, proximal duodenum situation. So it's not like a very.
Is it a stone?
I'm sorry?
It's a stone?
Right, it's a stone, right? So it's like equivalent of the gallstone pancreatitis, gallstone ileus, but it has like
it's like a Bouveret syndrome.
Yeah, it has
like gastric outlet obstruction.
Yeah, so this is like a nice example of Bouveret syndrome, but it's basically the same thing as gallstone ileus. But it was nice because you can actually see that there is a fistula connecting between the gallbladder and the stomach, where you can see ossification of the oral contrast going there. So anyway, so it was just a nice example of that.
Did they do okay?
She's still in the hospital. She's still in the hospital, and like this is like a week later. They decompress her stomach, but she's this is kind of stable, and it's harder to see on this one what's happening. You can sort of figure out, but I think the original one was nicer because you can see actually what's happening nicer, including the contrast extending into the gallbladder. All right, and my last,
And she has an MCN.
she does. All right, so this one's actually a very interesting case because I never seen this entity to this extent. So he's a young guy. I forget how, but you can see he's on the younger side, and you can see that his right kidney is normal, left kidney is just humongous dilatation of his calyces, tremendous dilatation of his urethra, and as you go down, just sort of kind of it gets lost. So he had an MR, which just sorry, it didn't come up right away for
There
whatever.
is no reflux on VCUG?
There was no, this is a fairly old study, so there was no VCUG, at least not in the in notes. So I believe based on the report, this was incidental. So the patient had an MR, because I think that rightfully thought, because when I saw it, I also thought maybe that this is ectopic ureter, and this is somehow just obstruction of the ectopic ureter. And this is the MR, and this is the sequence that shows this best. You can see this is a ureter, which is very, very dilated. You can see a lot of debris in the ureter, and then the distalmost ureter is right here, and you can see that it's kind of narrowed, right, like this.
It's like super dark, like scarred down or something.
Well, you can also see the same process on the right hand side, although not necessarily. So this is a path proven congenital megaureter, which I've seen a number of cases of, but I've never seen them to the extent where it actually causes hydronephrosis. So
can I ask a question?
Yeah.
So like the left distal ureter, like as it enters into the ureterovesical junction, it looks like scarred, like strictured. Was it patent?
Yeah, no. So what happens with congenital megaureter? It's I think, I don't know if I'm thinking about it correctly, but it's sort of analogous to Hirschsprung's, where the distal ureter doesn't peristalse, and you get just dilatation, and usually it's just dilatation of mid to distal ureter. And it's just a finding, and usually it's of no clinical, like it ends up not being significant. It's just like the distal ureter doesn't peristalse well, and this is the case where he probably has bilateral ureters are affected, but this is usually what you see, just kind of focal dilatation of the distal ureter. The worst I've seen, it was like half of the ureter involved, but I've never seen the ureter being completely blown out with associated hydronephrosis. And then so what they did is they resected the ureter, they reimplanted the ureter, and the path was whatever, like the hypertrophied vascularities in keeping with patients known, whatever, confirming whatever the diagnosis of congenital megaureter. And like, this is what patient looks like now, just kind of, they reimplanted the ureter right here, right? You can see that. And you can see that that little dilatation of the distal right ureter exists because he has that on the other side as well. And then now, like, a lot of things have decompressed, and he probably has reflux though, because of whatever. Anyway, so that was
Nelly was talking about that distal ureter looking dark. It looks like it's calcified here, so that maybe it over time calcified, but on the CT
no, I think that's they took the whole thing out, so I think that's just surgical material.
Oh, got it.
Yeah, because this is, they don't typically calcify. Usually usually they're just, all you see is just dilatation of the distal ureter. You don't even see that nice thickening. Usually just see and anyway, and when you see it, it's just the the ureter that's affected, and it's mostly, like, it's most pronounced distally, that's congenital megaureter. But I didn't even, and I remember from like Dr. Amos, teaching us that it's just the ureter that's affected, and that's how you kind of distinguish it from congenital megacalyces and things like that. So potentially this guy has both congenital megacalyces and congenital megaureter, and that's why it kind of looked like he was obstructed. Maybe
The
that's
renal cortex looked a little thin too. Did it recover? I mean, it was chronic, so probably didn't recover, huh?
he did not recover fully, right? Like he's still, but
Yeah.
his cortex, if you think about it, right, his cortex is more preserved than you would expect for this degree of obstruction and original dilatation, right? So like, look at that, right? So I bet that he has both congenital megaureter and congenital megacalyces. So
Yeah, I
that,
bet it's like a continuum, you know, rather than like, yeah, discrete things.
so I think they're actually two distinct. Well,
Oh, really?
from way back when, I remember from a resident, there were two, right? So, and the ones that I've seen separate congenital megacalyces, and I've seen congenital. I've never seen them together, but I bet you that's what he has, that he has both. But I can't prove that. That's my theory that I just came up with. So those are all my cases.
Cool, thanks. I'm gonna save my last one for next time. Does anyone else have a quick one? Okay, see you guys later. Oh, and actually next week we're not gonna have case conference because we will be at SABI. I'll see some of you there. And we'll see you in 2 weeks.
Have
Bye
fun
all.
at Sabi. Bye.
See you.
Bye.
Bye bye.